Test.
All right. So, like I said, we do have turning point slides. I got feedback from the class officers that you guys do want to do questions. Just timeline-wise, the questions you would submit would be able to go on exam 2. The quiz is Tuesday next week, so we just don't have that kind of turnaround time to do the quiz questions. So I've already submitted them for Dr. Carlson. So what I put in was there's an assignment tab. I mean, it's voluntary like last time, but we do have to get a certain number. You can work, the class officers asked if you could work in a group of 2 on a question, so maybe there's not quite so many questions, but that people could work together, and that's fine. The guidelines are kind of up there. I think, reflect back on if you're going to do it. It is a good exercise. And overall, the neutropenic fever questions were like 85, 90% correct on the final. So I think you guys definitely benefited from having them to look through and use them as a study tool. So it's really to your benefit. If not enough comes in, I'll have to make them. Also, I didn't really think ahead, but there are essay questions. So I could convert a multiple choice question into an essay response, or short answer response. So kind of think about that. I guess typically in thyroid, I probably put pathophys as a short answer question typically. So just keep that in mind when you're studying. And your API stuff is due tomorrow, is that correct? Your API preferences? So I know it's a hard decision. You also don't know availability of all the rotations. So look, that's definitely going to happen, and things change too. So just do your best on making choices. I know I ran into a P4 student, and they said people had been asking what my rotation was like and stuff. So I know that you guys communicate on the backside, which is fine, because you want to find out kind of what the real deal on the rotations is. If you are considering mine, mine is through Dana-Farber, but at Brigham and Women's, we round on the inpatients. So you get to go in and see patients every day with the team, and you work directly with a physician team. So there's direct patient interaction and rounding with physicians. So you get that collaborative team approach, which students tend to like. My rotation is rounds are relatively long, so that takes up a good amount of time. The physicians tend to engage the students, asking you questions that you have to follow up and do mini little in-services from time to time. It depends on the team. But that's what I do pretty much. And if you do get my rotation in January, what I tend to do, I start the rotation early. So when it gets released, who's matched into my rotation, I email you and say, don't go on a big vacation after New Year's. We're going to start earlier. So what I tend to do is I start 1 to 2 weeks before that block. Typically starts around MLK Day, but I move it up. And what that does is it creates a 2 to 3 week break in end of February, March, which I think is a better time to either get away or you're interviewing for residencies if that's something that you're interested in. So it opens up free time for residency interviews. Okay? And then I tend to take advantage of it, so and I like to go on a vacation too. So and actually I'm going to Mexico on Saturday for 2 weeks, so this week's kind of stressful, but we'll all get through it. You had your tests. I try to get 2 weeks of work ready. But we'll go through thyroid today. It's a relatively straightforward topic. You really should know most of the answers when it comes to the direct use of thyroid hormones. There's some additional things which you might have seen in community that you didn't really think about quite as much. Okay. So you have to understand the pathophys. The hormonal control of the thyroid gland is the HPA axis, which controls other types of hormonal processes in the body. So it has the regular negative feedback system, and so you need to understand that. Also, understanding the presentation of thyroid disorders, be able to make recommendations about thyroid disorders, be able to adjust thyroid hormone dosing, and talk about patient education. And then we have some special population things and also some drug interaction issues, kind of their disease state drug interactions, and we'll go through those when we get there. So thyroid hormones are formed in the thyroid gland, which is in your neck. They actually are formed as a large thyroglobulin, and this glycoprotein is stored in the follicles of the thyroid gland as a follicular structure. The glycoprotein is iodinated, and if you say that too many times, it starts to become a tongue twister. But the tyrosine residues are iodinated, and that helps to form active thyroid hormone. So in the thyroid, there's a sodium iodide transport that's active. It uses ATP to get a gradient. So the thyroid gland concentrates iodide, all right? And that's one of the reasons why radioactive iodine can concentrate in the thyroid if that's one of the treatments that can be done. So blockers of iodine transport include lithium, bromine, and fluorine. So those are kind of similar types of compounds or chemicals on the periodic table. But you guys learned about lithium, so what's lithium used for? Bipolar disorder, right? So hopefully that's a point you got on the test. I don't know if it was on the test that you just took. But lithium's for bipolar disorder. Lithium will inhibit iodide transport, so it can make people have subclinical hypothyroidism because it's inhibiting the iodide transport. And you probably learned about that as a toxicity of treatment. And so that could be one thing here. Also, depending on where you live in the United States, there's different iodide or lithium levels in the drinking water. So I remember when I lived in Texas, I think I think you could get blood levels of lithium of like 0.2 or 0.3 just from drinking water. And so that could have an impact as well. So it depends on the water table that's in a particular area and where the water's coming. Additionally, thiocyanates, percolates, and this other name, which I'm not really sure how to say right now, pertecanate, are utilized in labs. They are considered carcinogenic and toxins. Thiocyanate exposure will inhibit iodide transport and can lead to failure of the thyroid gland to work properly. So there's T4 and T3. We were talking about tyrosine residues. So the T stands for tyrosine, and the 3 and 4 stand for how many residues are iodinated. So T3 has 3 iodinated tyrosine residues, and levothyroxine, or T4, has 4. Now, almost all the thyroid hormone in circulating is T4, and a very small part is T3. Which one is more potent or more bioactive? T3, right? Because this would be the protective mechanism. The bulk of it is not as active, and then there's peripheral conversion. Also, most thyroid hormone from the thyroid gland is released as T4, and then we have peripheral conversion enzymes to give us T3 delivered more locally to our tissues. So the other thing is thyroid hormones don't just float around free. They bind to thyroid binding globulin, thyroid binding prealbumin, and also albumin, so they're highly protein bound. So it is possible to be susceptible to protein binding displacement from drugs. All right. So when we talk about drug interactions, we've gotten now, we could inhibit iodide transport into thyroid, leading to issues. We could have protein binding displacement issues with other drugs as well. And the protein binding is almost 100%. So these are very small free fraction issues, which if there is a displacement, you know, can lead to a big change because it would increase the free fraction significantly. So the amount of T3 actually made in the thyroid is only about 20% of the circulating T3, and the rest is converted peripherally. Now, there's different types of 5' monodeiodinase enzyme. Type 1 is in peripheral tissues. Type 2 is in the CNS, pituitary, and thyroid gland. So that would be the one that allows the thyroid gland to release T3. And then type 3 is in the placenta, skin, and developing brain. One of the things that we're going to talk about later, thyroid deficiencies can cause severe neonatal developmental problems. And that would be because type 3 is not getting enough T4. So we'll talk about that in a little bit, but this kind of links back to you need thyroid hormone in the fetus developing to have proper development occur. And type 2 enzymes in the CNS, then the type 1 is in peripheral. There are drugs that can inhibit these enzymes. One of them is a cardiac drug. Does anybody know which one that is? For arrhythmias? Amiodarone. Because remember, amiodarone can cause hypothyroidism and also hyperthyroidism. So it has both effects, but it has some inhibition of type 1 monodeiodinase enzymes. Okay? So I'm just trying to relate back some drug interactions to direct things we know about the hormone control so that they make more sense. They're not just random facts that you're kind of having to remember. The other thing is that these enzymes can produce a reverse T3 that is inactive. So there's a certain tyrosine residue that should be deiodinated for activity, and if it does the other one, then you'll have an inactive form and have reverse T3. Okay. So in the HPA axis, the hypothalamus is kind of the lead. Hypothalamus releases TRH with thyrotropin, and that goes to the anterior pituitary, which produces TSH, or thyroid stimulating hormone. TSH goes to the thyroid gland and then promotes production and release of thyroglobulin and eventually T4 and T3. And then again, the monoiodinase enzymes at target tissues helps to convert T4 to T3 to the most active form that gets taken into the cells and has an effect on the DNA and RNA replication. So the negative feedback mechanisms are T4 and T3. The anterior pituitary and the hypothalamus are supposed to be able to sense T4 and T3 levels so that if they are going too high, you should reduce production of TRH and TSH, respectively. If T4 is low, then TRH and TSH should upregulate, and you should get more of that stimulating hormone. Okay? Any questions there? So one of the frustrating things you're going to find, since you guys are getting closer and closer to APPEs, is I'll probably, at some time, you'll get asked about the HPA axis and how does it work, and you're going to totally blank out and not be able to remember the things. Everything is these two, right? Hypothalamus and anterior pituitary. The only difference is the gland. Is it the adrenal gland? Is it the ovaries? Is it the testes? So in this case, it's the thyroid gland. So 2 out of the 3 components is pretty much always the same. Pretty much everything comes from the anterior pituitary has stimulating hormone. So it's TSH or FSH or LH. So there's a lot of similarities in the terminology. So again, I'm a person who likes to make relationships. So if you know one thing, you can just modify it slightly, and you've got the answer to another, so that you're not memorizing 4 mechanisms, you're memorizing one with some permutations. So this always gets students nervous, the levels that you need to know. So we can measure a number of thyroid parameters. We can measure total T4 is the most common thing to be measured, as well as free T4. What I usually tell people is free T4 should be right about 1. If it's significantly off from 1, you've got a problem. Total T3, we can measure it. I tend not to use it in cases, although you guys are making cases, so you can choose to do that, which from my experience means that you probably will. So you guys like to be a little more tricky than me, I think. Resin uptake has to do with how much binding site is available for T3. Again, I tend not to ask questions with this parameter as being the key. Yes, we can do it. There are more advanced cases if there's problems with binding and uptake. What I tend to focus on is total T4, free T4, and finally TSH. The good thing, TSH should also be right about 1. So free T4 and TSH are about 1 in a normal patient. And if they significantly deviate, then, bless you, then there is a problem. We'll talk about factors and where it usually falls in hypothyroidism and hyperthyroidism specifically. So in hypo and hyper, basically you have opposite directions of these. And we're going to kind of evaluate each one as we go through. So we're going to do hyperthyroidism first. It's the one that you're not quite as familiar with. So we're going to start with a case. And it's a 35-year-old woman. She's nervous. She has anxiety, palpitations, heat intolerance, weight loss, and increased appetite. Probably all of us will be like, oh, the weight loss isn't so bad, but everything else isn't probably great. Her mother had thyroid problems. She does smoke and drink. She has a 2-year-old. She already is taking sertraline, and she's on orthotricycline. And then we see, what do you see about her labs? Is anything abnormal? I mean, her vitals, sorry. Tell me when something's wrong. Okay, so I think you're saying these are, BP's high, heart rate's high, respiratory rate's a little high too, which could be the anxiety, right? Okay, so hyperthyroidism is also sometimes called thyrotoxicosis. And thyrotoxicosis in some patients is also Graves' disease. There's some variations in these. Graves' disease is an autoimmune derivation behind it, where you could just have hyperthyroidism and you don't have all the presenting signs and symptoms. So usually the onset of symptoms present because of there's an extended period of time that people are actually hyperthyroid and they just don't know it. So symptom-wise, people have nervousness and anxiety, palpitations. It can be emotionally labile, have heat intolerance and fatigue, weight loss with increased appetite. Some signs, warm, smooth, moist skin. The hair can become more fine because there's a hypermetabolic rate. Oncholysis kind of is creepy in that the nails can separate from the nail beds because of metabolic rate so high. And then that's really painful too. You could have tachycardia at rest, wide pulse pressure, which means the systolic is much higher than the diastolic. So it's a wide pulse pressure. Also, because the person is tachycardic, you could have an ejection murmur just because of tachycardia, but they don't necessarily have underlying heart pathology. Men can develop gynecomastia. On neuro exam, you can find fine tremor and hyperactive deep tendon reflexes. The thyroid can be enlarged, but this doesn't have to be the case. Also, hyperthyroidism doesn't mean you have goiter. And you guys, what's goiter? Like the big neck, okay? Usually we see that in third world children and adults. Goiter is because you're not having enough iodine in your diet, and so you're getting hypertrophy of the thyroid gland to try to catch every little bit of iodine. What do we do in the United States to prevent goiter or iodine deficiency? We have salt. What kind of salt? We have iodized salt. So there's sodium iodide and there's sodium chloride in that iodized salt. Okay. So the picture up above is what we call exophthalmos. It's where the eyes are kind of bugged out. There's lots of pictures if you go on the internet. I also put up a couple YouTube videos. But exophthalmos is usually in people who have Graves' disease, and they have deposition of connective tissue behind their eyes, and it pushes the eyes forward. There's a lot of famous people that have had Graves' disease and also hyper and hypothyroidism. You can look up pictures if you want. But there's also retraction of the eyelids get pulled back. So the eyes are buggy, but it's also because the eyelids are getting retracted a little bit. The problem with that is that it doesn't always reverse with treatment. So if you've had long-standing Graves' disease and develop exophthalmos, you won't necessarily have that reverse. Okay? So we covered that we prevent goiter and iodine deficiency by putting iodide in our table salt. On physical exam, what would it mean to have a hyperactive deep tendon reflex? Any ideas? Right. So how does the provider test your deep tendon reflex? They have you put your leg up and they whack you. So if it's hyperactive, what will it do? You're going to, like you might get a little bit of a kick sometimes, but it's probably not good if you were to do that to stand in front of the person, right? So that's what a hyperactive reflex would show up like. Any questions? Okay. So we have to go back to physiology now and talk about pathophys. So there's multiple things that could technically be wrong that could make you hyperthyroid. But we're going to point out which ones are the most common. Okay? So we could have TSH overproduction. That could be a failure of negative feedback. You could have pituitary resistance to T4 and T3 receptors, or somehow they're decreased. Or it could be primary overproduction because of maybe a tumor or something else wrong in the pituitary gland. Okay? You could also have, so that covers like the TSH secreting tumors, primary overproduction, and resistance at the anterior pituitary. You could also, in Graves' disease, what happens is that there's antibodies that are anti-TSH antibodies that develop, but the problem is they stimulate the thyroid gland. So you have autoantibodies against TSH, but the autoantibodies are stimulating the receptor anyway, and you get constitutive or like constant stimulation of the thyroid gland. So you get lots of T4 and T3 produced. Negative feedback doesn't matter because in that setting, in the autoimmune setting, because the level is occurring at the thyroid gland. Okay? So what would happen in Graves' disease is they have a really low TSH, but they have a really high T4. And it's because here. If someone has a really high TSH, then it's the pituitary is the problem. So back to that initial chart we talked about. In hyperthyroidism, you can have a high TSH or a low TSH. It just depends if it's the autoimmune problem or is it a pituitary problem. Does that make sense to you guys? So thyroid toxicosis in the end is overexposure to T4 and T3. We look at patients, and typically they have elevated T4. Remember, the upper limit of normal T4 is around 12, so it's usually above 13. In this setting, most patients are going to be having the autoimmune type or Graves' disease, so most likely the TSH is less than 0.1. Remember, we said 1 is usually normal. Like if we tested everybody's TSH here who doesn't have a thyroid problem, probably somebody does, our TSHs would be about 1. There is a range that's wider than that, but most adults are about 1. If someone had a primary pituitary problem, however, the TSH could be 20, and the T4 could be high. So it is possible to have it the other way. If we tested radioactive iodine uptake in the thyroid, it would be elevated. The normal uptake is 10 to 30%. It would be greater than 30%. As I mentioned, however, when you look at the symptom constellation and the labs, T4 and TSH should solve your problems. You shouldn't need to look at these uptakes and bindings because they're a lot more confusing to figure out. Okay, so that's how I present the cases so that we're not like driving too deep. Definitely people do present with mixed results, labs that don't make sense sometimes, and then they go to endocrinologists for really very specific extra testing and stuff. So Graves' disease is the #1 cause of thyroid toxicosis, but not all people with thyroid toxicosis have Graves' disease. Okay? The incidence is 3 per 1,000 in the U.S. population. As I mentioned, it's autoimmune. Autoimmune antibodies against TSH, and they stimulate the receptor on the thyroid gland, and that's why you have high T4 levels. Negative feedback is still in place, and that's why the TSH is extremely low. Graves' disease has the extra symptoms of exophthalmos. You can also have pretibial myxedema, which, where's your tibia? The leg, right. So pretibial myxedema means on the top of the bone, there's it's like a slight edema and in the skin and puffiness. So it's not edema all throughout your legs, it's above pretibial, which is kind of just an odd thing. The thyroid can be enlarged because it is stimulated so much, so it could be 2 to 3 times the size, but you're not going to necessarily have goiter where it's incredibly huge. A systolic bruit is if, have you ever had a provider put their stethoscope to your neck to listen to your pulse? If you have a systolic bruit, would be hearing turbulence during systolic part of the cycle over the thyroid gland because of hypervascularity is what really it is. The thing with autoimmune diseases is spontaneous remissions are possible, but are we going to bank on it? No. Okay. So we've talked about autoimmune disorders before. What would the typical patient be with an autoimmune disorder if you had to guess? Or you could look ahead in the slides, but autoimmune disorder, is it a man or a woman typically? Woman, okay. How old is she? Is she your guys' age? Is she your mother's age? Is she your grandmother's age? That's generalizing and being, you know. So which one? You, your mother, or your grandmother? Your mother's age. So more midlife, 40s to 50s probably, right? And remember, what else did I teach you that was autoimmune? RA. Was it? So rheumatoid arthritis was women, midlife women, right? So autoimmune diseases in general, Remember, like, again, I try to kind of point out how there's similarities. You know some of this, but you kind of forget it. So it's a similar population to rheumatoid arthritis. Also, hypothyroidism is also autoimmune, so it hits the same population. Now, thyroid disorders are a little more, they can drop down into the 20s and even teens, but it's still women, all right? So many patients are midlife, but you can have people 20s and 30s as well. And that's a little different than RA, tends to be a little more midlife in particular. So additionally, we talked about genetics with RA a little bit, and they're actually very similar risk factors. So people that have HLA types, DR3, this also increases your risk of rheumatoid arthritis and other autoimmune diseases. And again, you wouldn't know this unless you did specific testing. Women are 8 times more common than men. Not to fret, there's lots of things that men get more than women as well, so we have our own problems. Identical twins have a 50% chance of getting a thyroid disorder if their twin gets one, versus 9% for non-identical twins. Now, 9% is the incidence that I told you already, though. What was the incidence in the general population? 3 per 1,000. So that's not 3%, that's 0.3%. So family members have increased rates compared to just the general population. So you can see the magnitude of family history versus if you had an identical twin. Because you have the same genetics, the same experience, your increased likelihood there. And again, you have family clusters, and what you see is families have, one person might have hyperthyroidism and one person might have hypothyroidism, but they're all autoimmune and they increase the risk of each other in the family. So management of hyperthyroidism, we have a couple of objectives. We need to manage the excessive thyroid hormone problems and minimize long-term consequences. We also want to get kind of baseline thyroid function back to a normal level. Some things that we can utilize include surgery, radioactive iodine treatments, and anti-thyroid medications. Generally, surgery is not what is done. There are some patients that do get surgery. In particular, pregnant patients are a little more likely to get surgery because we don't want to give radioactive iodine to pregnant women. Hyperthyroidism isn't going to get better typically on its own, so anti-thyroid medications can be a long-term management tool, but you're probably going to need some radioactive iodine in those patients. So what is excessive thyroid hormone manifestations in the patient we talked about? She had anxiety, she had nervousness, heat intolerance, a bunch of symptoms. We can manage some of those. Anti-thyroid medications are going to help decrease the level of thyroid hormone in the body. And then usually what we try to do is get people medically stabilized, and then they'll get radioactive iodine a little bit later. After we get them under control with those other two things. And we'll talk about how do we do each one. So surgery is very rapid and effective. It's safe in pregnancy. It's invasive. You can get nerve damage. You're definitely going to be hypothyroid after you take out the thyroid gland, so then they'll need thyroid supplementation eventually. Radioactive iodine is very cost effective. It can, quote unquote, cure people, getting the thyroid function back towards normal. It doesn't get rid of the autoantibodies per se, though. The cons, again, hypothyroidism is very common, and you can't get pregnant for 6 to 12 months after having radioactive iodine because it'll inhibit the ability of the fetus to get iodine, so you don't want to have that happen. So if you have a childbearing age woman, they need to either contraception or some strategy to not get pregnant during that time. The anti-thyroid hormones or medications are non-invasive. They have a relatively low cost and low risk, and initial therapy for severe and pre-op patients. So most patients will get anti-thyroid medications first when they present. Unfortunately, they don't really cure the problem. The underlying thyroid stimulation is still happening. They're working to block peripheral conversion mostly. And they have their own side effects as well. Again, most of the time, I'm not going to focus on surgery as the outcome for cases or questions. However, people with larger glands, if they have severe ophthalmic issues like exophthalmos is a major problem, and you want to get rapid resolution, it's going to happen better with that. Or if thyroid hormone, anti-thyroid medications are failing or not working, then we might go towards surgery. If we're going to do surgery in someone, we give them anti-thyroid meds. Methimazole is one of the options. It's the most likely to recommend. So methimazole should be the one that you choose if you can't remember which one to choose. They take that for 6 to 8 weeks, trying to get the thyroid hormone levels more normal, and then going to surgery. Additionally, prior to surgery, we give people pulse doses of iodine to inhibit the thyroid function. So one of the things about the thyroid gland is if you get a lot of iodine at once in your diet or intake, the thyroid gland will shut down for a period of time. And so that's an advantage prior to surgery to decrease vascularization, decrease complications. And also, when they go in to take out the thyroid, there can be a surge of thyroid hormone release from that, and that could be damaging to the patient. So if we inhibit thyroid function with iodine doses, that's going to reduce the risk of that happening. Finally, and this relates to our case, we can control tachycardia, nervousness with beta blockers. Beta blockers, particularly short-acting, not the long-acting, we use propranolol typically. We give this several weeks prior to surgery and also post-op for another week or so to control any symptoms of hyperthyroidism. So prior to surgery, you're getting methimazole for a month or two, you're getting propranolol for several weeks, and iodine very close to the surgery to inhibit the thyroid gland. So I talked about methimazole primarily, but there is another agent, propylthiouracil. Have you guys ever dispensed either of these? No? Okay. So they're not totally uncommon, but again, this is usually in people who are early on in their disease. Also, you'll see that these are used in pets. Pets can be hyperthyroid, and methimazole is used in cats and dogs as well. So veterinary prescriptions will come in through the community. Methimazole is dosed 30 to 60 milligrams a day, but what we do is divide it into 3 doses. So that 30 milligrams, the starting is really 10 milligrams TID. And if you're not getting an adequate response, you can go up to 20 milligrams TID. The max is 120 a day. It takes 4 to 8 weeks to get a reduction in thyroid levels. So anti-thyroid hormones, you start 10 milligrams TID. You're going to monitor the patient and recheck hormone levels like in a month. You're not going to do it in a week for this outcome. In patients, you can also taper the doses after they get under control. They don't need 3 times a day dosing. That's where they can go down to like between 5 and 10 milligrams a day is a common maintenance dose if that's what they stay on. It can induce a permanent remission that lasts a year or two in about 50% of patients. So it is something that can work for a period of time in patients. If they escape and it breaks through, they may become hyperthyroid again, and then we might have to go towards surgery or radioactive iodine. This is important. It's preferred. There are FDA warnings about PTU or propylthiouracil, specifically hepatotoxicity and myelosuppression. So methimazole is the preferred agent. However, PTU is also available. The nice thing about PTU is it's just 10 times the dose of methimazole. So 300 to 600 divided in 3 to 4 doses. So that's kind of a nice thing. How these work is they inhibit peripheral conversion of T4 to T3. Again, very similar things here. Remission rate's the same. But this is what you probably want to circle. In pregnancy, PTU safety is documented. So in pregnancy, we use PTU or propylthiouracil. In everybody else, we use methimazole. So you guys know that's really easy to write questions about. So, do you guys have any questions there? So these are considered thioureas, as that's their kind of drug class. Predictors of response, patients that are a little bit older, over 40, if they have a low ratio of T4 to T3, so they don't have very high levels of T4, their thyroid gland is not significantly enlarged, they haven't had disease for quite a long time, low antibody titers is also an indicator that they may respond, and if you relapse with hyperthyroidism, then you can always go to radioactive iodine therapy. So the problem with this, you don't need to be over 40 to get methimazole, okay? You don't have to have a small thyroid gland to get methimazole. These only predict better chances of response, okay? So don't take it to the extreme and say, oh, these are hard, like it won't work anymore in those other patients, okay? So we can use methimazole or PTU in anybody based on their own factors, but this predicts better chance of response. So drugs cause problems, and these drugs are actually relatively well tolerated, but they have some significant bad toxicities that require interventions. So minor reactions is up to 20% of the time, major up to almost 5%. The cross-reactivity between the two is about 50% chance. So you could get the reaction with one agent, try the other, but the cross-reactivity is significant in the chance that you'll get the same reaction. Pruritic maculopapular rashes with vasculitis, about 5%. You could try an antihistamine for the pruritus, but you might have to rotate agents or stop. What antihistamine would you use for pruritus in a patient? First generation, second generation? Do we know what that means? First, and what's a first generation antihistamine? Yeah, diphenhydramine, hydroxyzine could be used as well. More so than like loratadine or citrazine, I would use a first generation initially at least. Arthralgias can occur usually 6 months into therapy or longer is when these show up. Fevers, leukopenia in about 12% of patients, mild, but we can get agranulocytosis where the ANC is less than 250. There's a slide at the very end to remind you how to do the ANC. We did it in the neutropenic fever. But it's less than 1%, so this is good, but if this happens, they have to stop the medication. And it's most common showing up in the 3-month range, and the higher the dose, the more likely it's going to happen. Bless you. So bad things would be agranulocytosis or the maculopapular rash that can't be managed with antihistamines would require stopping and rotation. GI distress is, again, about 5%, but hepatotoxicity is seen up to almost 2%, again, in the first 3 months of therapy. So the nice thing is some of the really bad stuff happens early on. If you get past that phase, the likelihood is going to decrease. Mild elevations, less than 3 times normal, you can probably stay on the drug. If it's more than 5 times normal, you're probably going to have to go and stop that medication. Okay? And remember, this is the FDA warnings around hepatotoxicity and agranulocytosis are more severe with PTU. And that's why it's not preferred. Any questions on thioureas? Good? Okay. So iodides, I've already kind of given you the mechanism of action. It's interesting that these have 3 different things they do. They acutely block thyroid hormone release, and remember, we already talked about that's an advantage in surgery, and also prior to radioactive iodine treatments. They also inhibit thyroid hormone synthesis when given in large doses. And they decrease the vascularity of the thyroid gland, which again is an advantage prior to radioactive iodine or surgery. The onset is 2 to 7 days, and you're going to see a reduction in T4 and T3 levels for several weeks, but not for months. The thyroid gland will escape the inhibition within 1 to 2 weeks. So that's why we don't give it 3 weeks ahead of surgery. We give it the week prior to surgery. So a couple products we can use. Has anybody ever dispensed SSKI? Okay, so supersaturated potassium iodide. It's 38 milligrams of iodide per drop, and you put 3 to 10 drops daily in water or juice. Do you think this is going to taste good? Really bad, right? We usually start a week prior to procedure and 3 to 7 days prior to radioactive iodine. So 7 days prior to either one will work, okay? Lugol's solution is a less concentrated iodide solution with only 6 milligrams per drop. So you're going to need more drops of Lugol's to get the iodine you need. So pretty much, if you see SSKI or Lugol's being dispensed, it's probably for hyperthyroidism. Again, unless someone comes in with a goiter, then that might be for that as well, but it's really used in these settings. So it's a limited use. Also, from what we've seen, should they be getting this for months and months at a time? It's a very small time frame, maybe 2 weeks to 3 weeks max. So you shouldn't be getting large volume prescriptions with multiple refills. So iodines also have their own problems. What's an allergy that would make you concerned for giving SSKI to a patient? That's very common to see in patients. Sometimes they'll say iodide allergy, so that should be like a good clue. But what has iodine in it as a food that leads to allergies? Shellfish. So people who have shellfish allergies may react to like SSKI or Lugol's. Hypersensitivity reactions can occur. You can get skin rashes, drug fever. You can get rhinitis and conjunctivitis. Iodine can also cause swelling of your salivary glands, and they can be painful swelling. Iodinism is overdosing on iodine, and some of the things you can see are metallic taste. You can get burning in the mouth. Your teeth and your gums can be sore. Again, you can have the rhinitis occur, stomach upset, and also can cause gynecomastia as well. So iodine, although it seems like it would be an innocuous thing, in superdoses you can end up with some problems. Any questions on iodines? So beta blockers, hopefully we know the mechanism of action of beta blockers. These have been driven into you guys since hypertension and congestive heart failure and all those cardiac diseases for a long time. They block adrenergic receptors. Hyperthyroidism causes a state of high adrenergic stimulation, which leads to palpitations, anxiety, tremors, heat intolerance. So beta blockers can directly benefit those symptoms. Dosing, as I mentioned, we use propranolol. I would start with 20 4 times a day, If the patient doesn't adequately respond, go up to 40 4 times a day. You can go to higher doses. Most people can be managed on the lower doses. Typically, you want your goal heart rate less than 90. Also, resolution of anxiety and heat intolerance is a nice thing to see. If someone can't take a beta blocker, you could try diltiazem 60 4 times a day as well. You could also up titrate it if you don't get resolution of the tachycardia. All right? But you do need to monitor the blood pressure as well. But the racing heart is the symptom patients feel the most. That's why we're using that as a parameter. Radioactive iodine is a beta emitter as far as radiation goes. Beta emitters do not penetrate very far from where they get deposited, so that's actually a good thing in that you're not getting radiation exposure throughout the body. It's really localized to the thyroid gland where it's being localized. The half-life is 8 days, so it doesn't have a super long half-life. It's given in a single dose to patients. And typically, your efficacy rate's about 60% within 6 months. And patients can continue to respond for up to 12 months. So you continue to monitor their thyroid levels and see how they're doing. If there's a very poor response, you can give a second dose after 6 months has passed, giving it at least enough time to see if there's an initial response. Typically, again, in questions, I focus on the initial dosing. I don't usually make scenarios of where you'd have to decide on a second dose, because I think those are kind of complicated situations. But if someone wasn't having thyroid hormone levels respond at all, continuing to have symptoms, they would be a candidate after 6 months. The radiation does destroy thyroid gland tissue through the beta radiation. So you will see a decrease in size of the thyroid gland. Also, it's not as titratable as you might think. One dose may reduce levels by 40%, but they're still hyperthyroid and they might need another dose. Or they might go on to methimazole to get that person to maintenance levels. If we give second and third doses, the chance of getting hypothyroid get greater and greater. So we can overshoot and become hypothyroid very easily. It's a first-line option in patients with Graves' disease and like nodules in the thyroid gland that are autonomously making thyroid hormone. Also multinodular goiter. We're focusing mostly on Graves' disease ourselves. Initial release of thyroid hormones can be seen. So when we use RAI therapy, they get a thiourea and a beta blocker starting on the day of treatment and for at least about a week after, about 4 to 6 days prior, and then at least 4 days after. So you're looking at about a 10-day window of beta blockers and thioureas to block any surges that occur. And again, long term, you have to watch for hypothyroidism months to years later. Okay, we're getting closer to the treatment component because, again, this is the one of the two topics that you guys don't know as well. Hypothyroidism is very intuitive. People can get what we call a thyroid storm, where they have very high levels. They have some of the symptoms we've talked about, but they might also be hyperthermic or have a fever, tachycardic, tachypnic. They might be dehydrated with a delirium and a coma. Things that can trigger a thyroid storm include infections, the surgery, the radioactive iodine treatment. If they stop their antithyroid meds, that could also trigger it. It can last for several days. Mortality is very high. These type of patients would end up in the ICU, but typically what we would do is start thioureas, beta blockers, corticosteroids. But what you notice is we might start on the higher end of the dosing range if someone was going to the ICU for thyroid storm. And your markers there would be like delirium and coma, very febrile patients with tachycardia, hypertension. So our patient doesn't really fall into that category. but if we gave her radioactive iodine, she could potentially get there. So this is a more extreme manifestation. Also, if someone is NPO, we do have IV beta blockers, either propranolol or esmolol are things that we can utilize.
Are you saying that those are the options we would use in this patient? Or
No, they would get all of these. Yeah, because you want to block the thyroid effects. You want to block all this cardiovascular storm happening. And steroids always help us when we're in a stressful situation. So this is stress dosing of steroids. So, good question. And then if there's other complications, you might treat that. With the fever, you might do antibiotics. Is it an infection that we're not sure about? So you have to look at the other parameters on the patient too. But this would be our core for the thyroid problem. Okay? Any other questions? All right. So flow diagrams, we like these. Hopefully you guys also try to make these yourself, because it does help you perform better on exams and quizzes. So we've got here the hyperthyroid patient. If they're tachycardic, we can give them a beta blocker or DILT as an alternative. We've identified the hyperthyroid. We're typically going to give methimazole for a period of time, even if we're considering RAI therapy or surgery, because we want to get that person into more under control and out of this symptomatic situation. If they are pregnant, then we'll use PTU. Now, so this is kind of where our overall plan is in the upper levels, but the methimazole causes problems. So depending on how long you're on methimazole, if you get a rash, we're going to try an antihistamine. We already talked about first generations. If somebody presents with fever and you check their white count, and their white count is low, we're going to worry about agranulocytosis, and we might have to stop the agent. And then remember, the other big constellation was nausea, vomiting, abdominal pain might indicate liver toxicity. So rule out hepatitis, check the LFTs. If they have some nausea, maybe try an anti-nausea medication or consider rotating. If these symptoms are too problematic, you might have to go towards radioactive iodine therapy or surgery. So this is your monitoring follow-up component that you're doing while they're on methimazole. This could occur while you're waiting to do radioactive iodine. It could occur if you're choosing methimazole extended therapy and you want to monitor for these at any time. So anybody on methimazole or PTU, we're doing this. And then we just have to think about what's our goal, where are we going. Does that make sense? Okay. As people become more euthyroid, you can reevaluate the need for the propranolol and diltiazem and potentially back off on that as well. So people shouldn't need long-term beta blockers. So if you do stay on the methimazole, for example, that's our approach, which medical management is okay to do. We can maintain therapy, check T4 and TSH in 4 weeks. Remember, we said it takes 4 to 8 weeks to see changes. So we'll check in 4 weeks. If things become more euthyroid, we may be able to titrate the dose down. If patients start to show signs and symptoms of hypothyroidism, we would also titrate the dose down. This is an alternative pathway. Sometimes you find a dose of methimazole that works to block the hyperthyroidism, but they're a little hypothyroid, and you can add a small dose of levothyroxine. This does happen, but this wouldn't be my primary plan. If they have hypothyroidism, I would try to titrate down. And remember, in the long term, a maintenance dose is probably going to target 5 to 10 or 5 to 20 milligrams a day. Because initially we need more to get that person euthyroid, which means normal levels. And then once we get them normal, we can start to titrate down. And when they're on chronic therapy, we need to be checking TSH and T4 like every 3 months. You can extend it a little bit. 3 months is a good idea. Any questions? I'm going to finish up our hyperthyroid block before we do the break, just so we have a clean break with this stuff. So we're back to the patient. She has nervousness, anxiety, palpitations. You guys identified the heart rate and the BP you're not real happy about. We find that her TSH is less than 0.1, her free T4 is 22, and she has positive antibodies. This would take more than like an hour to get this data. So this would be like the thyroid would come back probably in several hours. The antibodies would come back the next day when the lab runs them. So is she someone, what approach should we initially go towards? Would we go right to surgery, radioactive iodine, or would we medically manage her first? Any ideas? Does surgery sound like a good idea right away? No, because you could get the thyroid storm, right? Radioactive iodine, you want to get someone, again, more stabilized. So medical management becomes an early option, and then you can go consider these once you get people under better control. Anything else we need to know? Are you pregnant? Good. So, would she benefit from propranolol? Okay, yes. Should we start propylthiouracil or methimazole? In this setting, the pregnancy test comes back negative. Okay. Does she need SSKI? For medical management patients, do they need that? No. Would surgery or radioactive iodine probably be more likely in her future? Radioactive iodine. This is our primary method. We don't like doing a lot of the surgery stuff. Okay. So I added these questions. If we changed the scenario and the pregnancy test was positive, what would change? We'd use propylthiouracil instead. What if she said, you know, I'm 35, I just got married 2 years ago, we were planning on having kids soon. Surgery might be more likely, but what would you probably avoid in her? Right, so the radioactive iodine may go down your list in like second phase planning for her management because you know she wants to get pregnant, okay? Can she be on propylthiouracil and be pregnant, right? So if you can get her controlled medically, she could technically have a baby on propylthiouracil, okay? Good. All right, so clicker time. If I can bring up that window. Awesome. Sorry. All right. We answered this already, but what's preferred in pregnancy? I know I better not go for like 100 people because I don't think we have. All right, 20 is good enough. Answer A. And it's good that nobody did D, so we're making improvements. Which of the following adverse reactions would require discontinuation? Hepatitis, rash, or abdominal pain? And if you do the question assignment, don't use these questions to submit. Because everybody's seen them already. Right, hepatitis, good. All right, so we'll go ahead and take our break. Grab something, get a drink. You're so nice to them. Let's see. Is that working? Yeah. You're not really going to listen to this one, are you? Maybe, you never know. Okay. Okay. So hypothyroid. Did it stop again? Okay. So etiology, autoimmune thyroiditis is also called Hashimoto's thyroiditis or Hashimoto's disease. Those are kind of different terms for the same thing. That's the #1 etiology in adults. We also have iatrogenic, which is typically people who've had surgery or radioactive iodine therapy. We've caused the hypothyroidism in them. You could also have iodine deficiency and thyroid hypoplasia for various reasons, but by far, #1 and #2 are listed as things that are going to come up for us. Secondary, you could have pituitary failure. So the pituitary gland could have something wrong with it. It's not making TSH, so that could be a problem. Or hypothalamic dysfunction could cause TRH deficiency. So you could have things going on in the brain that are affecting the HPA axis at higher levels. But those are very uncommon. Autoantibodies can target a multitude of things. Typically, they're antimicrosomal, and they target thyroid peroxidase. They can target thyroglobulin and other antigens on thyroid cells. So not everybody has the same autoantibody, but the end result is autoimmune hypothyroidism. Antibodies that can fix complement also have the ability to kill thyroid cells. So a lot of these antibodies are complement fixing, and that's how they are killing the thyroid cells as well. So signs and symptoms. What can you misconstrue as the problem in someone who has these types of symptoms? What other disease state that you've learned about is probably your highest risk to get confused? Depression. So you have to think about depression. This has some additional symptoms that are more physical, right? Cold intolerance. The changes in weight are a little more pronounced. Cramping, dry skin, changes in hair, those don't happen so much with depression. And then I'm sure when Dr. Marino went through it, anybody who comes in with depression symptoms, you have to make sure they're not hypothyroid. And you've got to correct hypothyroidism before you can diagnose depression in somebody for sure. So these are very closely linked in constellation of symptoms, but this patient is not going to present with the same level of lack of interest and other things that you're going to see with strict depression patients. Okay? So again, weakness is another symptom. You have proximal compared to distal is a little bit more pronounced. You can have periorbital puffiness and bradycardia, slow speech. You could have a goiter, but that's not common. Also, carpal tunnel syndrome symptoms and neuropathy symptoms are not what you see with depression. So there is a wider constellation of symptoms possible with this than just depression. So typically, you see everything is decreased and the TSH is increased in patients who have these autoimmune thyroid problems. The problem that you can run into is hypothyroidism. When you get diagnosed, you've probably had it for a time. It takes a while to evolve to the level where your symptoms are severe enough for you to seek help. Initially, what will happen is you'll see rising TSH. You'll still have a normal T4 because body stores are still there in the thyroglobulin. They're getting released. That's where you're still getting your thyroid hormone, and you're not going to have as many symptoms. And then as time goes along, the TSH will continue to be high, but the T4 will drop. T3 will still be maintained because you're going to convert whatever T4 you have to T3. So again, symptoms are starting to develop, and then eventually you can have a low T4 and a low T3 as stores get more and more depleted. So there's an evolution in the labs, and depending, you could catch somebody at an earlier phase where they just have a high T4 or a high TSH and still a normal T4. So one of the things I like to go through is the products. Has anybody ever dispensed Armour Thyroid? What's the age of people who usually get Armour Thyroid? Are they your parents' age or are they more your grandparents' age? Usually the older patients have been on this a long period of time. Where does Armour Thyroid come from? Do you know? What's that? It's pigs, porcine. So they take the thyroid glands out of slaughtered pigs and they desiccate it, so they dry it out, they grind it up, they make a little tablet. Okay? So if you were a new diagnosis of hypothyroidism, would you want a human synthesized hormone or would you want porcine? Okay, so human synthesized now for new starts, everybody gets levothyroxine typically. People can still have trouble with the formulation like dyes and other things. I'm sure you've had patients come in and say, I can't have levothyroxine, I have to have Synthroid, but, you know, and it could be dyes and excipients do cause problems for patients sometimes. Armour Thyroid is from porcine in nature. There's also Westroid and Natrithroid. One of the things, though, I like to have you remember is grains. So how much is in a grain? Yeah, there's a mistake here, right? This should be milligrams, not micrograms. All right. So a grain is a pharmaceutical measurement where you have either 60 or 65 milligrams, okay? There's some products on the market that still are in grains. Armour Thyroid comes in quarter grain, half grain, grain. grain and a half. I've listed the milligram size for you there. Also, they're not bioequivalent, right? Because if you're talking about porcine thyroids, the different products are made in different ways. So the dose on one is not the same. The other thing is these products are also refrigerated in the pharmacy. When people go home, they don't have to if it's a month supply, but in the pharmacy, we keep them in the refrigerator. Levothyroxine is T4. You can see that there's many different strengths. What's the highest strength anybody's ever dispensed? 200? Anybody do the 300? So what does that tell you? Should we be using 2 and 300 typically? What's the most common strength? I see a 50, 100. Any others? 75. Most people will fall within 50s on the low side, but 75 to 125 range is the typical range for adults. Okay? So again, you have experience dispensing these, so you should have an idea. The older and the littler the person, the smaller the dose that they may require. We also have Levoxyl and Synthroid. Technically, you shouldn't be just switching between products constantly. We try to dispense the same manufacturer. Liothyronine is T3, so we do have a synthetic T3. The half-life of T3 is much shorter, and so it's dosed in the microgram strength. It's multiple times per day, 2 to 3 times a day that you would use liothyronine, but it has much more side effects. It is more likely to cause palpitations, GI distress, nervousness, because it's the active form. So typically we don't use T3 unless you have a peripheral conversion problem. And then there's also Liotrix, which is a combination ratio 4:1 of T4 and T3. One of the brand names is Thyrolar. It's also in grains. So I do want you to know what a grain is equivalent to, because we see it in these potentially in this disease state again. IV to PO, the conversion is levothyroxine is about 40 to 80% bioavailable. So most of the time, what people do is 50 to 75% of the PO dose is given IV. Most of the time, people will just go with 50% to make sure you don't overdose. So if you have 100 micrograms PO, use 50 IV. In the inpatient setting, there are times we use it on a regular basis, so knowing a 50% conversion is a good idea because you are going to use it on your APIs. Okay, so hypothyroidism, we need to replace thyroid hormone. Average daily doses, there is a weight-based 1.6 microgram per kilo per day, which for like a 70-kilo person would come towards 125 micrograms. You do know, and you mentioned that lots of people get between 75s, they get 88s, 100s, and there's a lot of 112s and 125s. So you see definitely doses in those ranges are most common. The good thing is that because they have very tight dosage ranges, when you titrate up, you could titrate up by about 12 to 13 micrograms increments once you're in that kind of dosing range. So initially, people that we need to be cautious are elderly and people with cardiac disease because we don't want to stress their heart. And so we start with lower doses of 12.5 to 25 mics daily. And you can titrate the doses by 25 microgram increments until you get to about 75, and then you should probably go down to a smaller incremental dose increase. Healthier patients, you can start 50 to 100 micrograms and titrate by, again, the smaller range. If I started at 50, I could go to 75 on the first titration. If I start at 75, I might go to like 88, okay? So using a conservative approach is a good idea. It takes about 6 to 8 weeks to see the rehomeostasis balancing of the T4 as well as the TSH. So we can monitor the physical symptom improvement, but the hormone improvement takes more time. So we can give 6 to 8 weeks between lab monitoring, but we can do dose titrations in the early phase more rapidly. Once we get to a target dose that has alleviated a good number of the symptoms, we can leave them on that for a month or two and recheck the labs. So that's what this really depicts, is that you can use smaller starting doses in the elderly or a higher dose in the more healthy patient. Are there any signs of toxicity? So that means you've started this in the first week. Does the person complain of tachycardia and nervousness? Are they having trouble with the dose? Then that means you're giving too much, and you might have to maintain or decrease the dosage. If they're having no signs and symptoms of toxicity and the symptoms are not dramatically improving, like energy level, that sort of thing, you can increase by the increments that we talked about until you get every week, until you get into a target range that you think they'll get a response. So we use symptom improvement or symptoms of overdose to manage our dosing titration. Once we get to this target dose, then we go into checking the TSH and T4 from a laboratory perspective, again, in the 1 to 2 month range time frame. As people become euthyroid, you keep them on the dose. Again, euthyroid means their hormone levels are normal and their symptoms are improved. We can recheck them every 3 months and then eventually move them out to every 6 to 12 months. So people that have been on Thyroid for 10 years are not getting checked every 3 months. They're getting checked every year. But it's a titration out to that level. Kind of similar to warfarin and stuff. Hypothyroid patient who's still having symptoms, we can increase by our interval, 12.5 to 25. And again, we can still recheck the hormone levels, but knowing if you're changing the dose, it takes time to get to steady state. Okay. So product-wise, we want to choose a product and fill prescriptions with the same manufacturer. There are minor variations in bioavailability. So remember, we're titrating by 12 micrograms, so a minor variation could have an impact on the patient's symptoms. And patients definitely, there's products they like and there's products they don't like. So there are drug interactions that are related to therapy. So basically, we've covered some of these. When you think of thyroid hormones, think about the fact that when you're hypothyroid, your metabolic rate is low. Your liver enzymes and CYP enzymes are also underperforming. When you're hyperthyroid, you're hypermetabolic and your CYP enzymes are also hyperactive. So it almost is like you're an enzyme inducer at that phase. And when you're hypothyroid, it's almost like you have an enzyme inhibitor going on. Do you see what I'm saying? So as you come euthyroid, you move away from those abnormal states, and your enzyme activity is more normal. So it depends on where you started from to where you are now. So we can have decreased absorption through binding, cholestyramine, psyllium supplements, which is Metamucil for bulk-forming laxatives. Iron, sucralfate, and calcium can all bind your thyroid. Also antacids, so we have to separate administration by 2 hours from those things. So there's a lot of people in that time frame or this age range that might be using those, so make sure you talk to them about that. Also remember, midlife women are very likely to be on calcium supplements. You might say, oh, you should probably be taking 1,000 of calcium a day or 1,200, so you need to space that out. We already identified amiodarone can inhibit peripheral conversion. that doesn't mean we're going to put all those patients on liothyronin, but they may require a higher dose of levothyroxine to get the euthyroid symptoms or euthyroid state. Also, if you have a selenium deficiency, you can have inhibition of conversion. That's probably not going to happen unless you're on TPN and they're not giving you selenium. So, decreased clearance of T4 can be done with things like carbamazepine, rifampin, and phenytoin. So there can be decreased clearance and prolonged effect. So what this chart is looking at both hyper and hypothyroid states. So sympathomimetics are beta agonists. In the hyperthyroid patient, they have increased sensitivity. So if you were to give epinephrine to someone who's hyperthyroid, you might actually give a little lower dose because they're hypersensitive. In the hypothyroid patient, they might have a blunted response, and you might need higher doses of those agents. Digoxin. Digoxin has increased VD and clearance, so you may need a higher dose in the hyperthyroid, and then in a hypo, you may need a lower dose. So as you correct their disease state, you may have to adjust the doses down or up, depending on where you started from. Insulin clearance is increased in hyperthyroid, so they may require a higher dose, and then as you get them euthyroid, you have to lower the dose. Okay, so you might see increases in hypoglycemia as you become euthyroid. In the hypothyroid patient, the opposite is true. They may require a lower dose because clearance is suppressed. As you increase the metabolic rate, you might have to increase insulin to get the same effect. Warfarin is kind of an interesting one in that you have increased clearance of clotting factors, so you use a decreased dose in the hyperthyroid. But in hypothyroid, you might actually have a higher dose. And again, as you become euthyroid, you have to correct that dosage adjustment. Okay. Levothyroxine is interesting in that the half-life is actually decreased in hyperthyroid patients and increased a little bit in the hypothyroid. And that will change a little bit too. So that's just the natural half-life that's in your body. Cortisol, patients can have extended duration of cortisol or like hydrocortisone and other things, and it may be chewed up faster in the hyperthyroid. So you might have to use more steroids to get the same effect in the hyperthyroid. Okay. Does that make sense to you guys? Sometimes people have trouble remembering kind of how we went through that, so that when you're later on. But remember, this is talking about patients are starting here, and we're bringing them to the middle, so we're correcting these differences as we make them euthyroid. Okay, good. So there's some special populations, and we are going to come back to the patient. People who are hypothyroid very severe for long periods of time, and then they get a significant stress, like they have a car accident and have breaking all these bones, they have sepsis, a severe infection. The stress, their body can't deal with it anymore because their metabolic rate is suppressed. They can develop hypothermia. They can develop delirium and coma. They will have decreased deep tendon reflexes. They may have hypoglycemia, hyponatremia. So these patients are high risk for dying. And you can see the mortalities listed. What they require is high doses of levothyroxine initially, 300 to 500 micrograms a day. This is in the ICU setting. This is the IV. So this is more like 600 to 1,000 micrograms of PO. Once the person's delirium is correcting and stabilizes, we can start to lower the dose. But we also give corticosteroids to support the metabolic problem. So you guys know in sepsis or septic shock, there are instances you could have given hydrocortisone when you talked about that. Mixed edema coma would be one where you could do stress dose 100 milligram Q8 to support that patient as we try to rapidly correct their thyroid deficiency. Okay. As they stabilize, we would decrease the dose to 100 micrograms every day. Sorry. All right. I'll put these back up for you. before we're done. Okay, so mixed edema coma, again, is a very outlier severe state. The person's coming in with long-standing symptoms and they're delirious, probably comatose. You identify very, very low T4 levels, high TSH, and they're not getting treated. So that would be kind of the scenario for that patient. What about hypothyroidism in pregnancy? Pregnancy can cause it, but you can also be pregnant and hypothyroid at the same time. Remember, because the fetus needs thyroid hormone to make sure they don't have developmental problems, we typically will target a TSH of around 1. In the pregnant patient, we want the TSH to be less than 1 and definitely have a normal T4 level. Up to 75% of women do need dosage increases during pregnancy. So during pregnancy, if you started on 100 micrograms per day, throughout the pregnancy, they're going to keep checking the hormone levels more frequently, and you might have to increase the dose. After postpartum, you will need to come back down on the dose as well. Other special populations, we do know that as women age, they may need some dosage increases or decreases. Again, this is primarily a bulk of women in this disease state. When women go through menopause, there could be about a 35% increase in the dose that's needed. So the decreases in estrogen sometimes require increase in the levothyroxine dose to make sure they don't have symptoms continue. So as they go through that phase of life, you might have to have a dose increase. However, as they continue to age and become more into the elderly range, dose reductions may be required. They may lose weight. Activity levels may drop. That same dose may now start causing some anxiety, palpitations, increases in blood pressure. Okay? So that's a very subtle change over time in a geriatric longitudinal population. It would be kind of hard to write a scenario where it would be time to make that change. But knowing in the geriatric population, dose reductions is not uncommon over time. Okay, we actually are getting very close to the end. There are a couple other things that I do want to talk about. Subclinical hypothyroidism and euthyroid 6 syndrome, because you'll see those in patients in clinic for this subclinical hypothyroidism, and euthyroid 6 syndrome you see in acutely ill, so when you do your APPEs, internal medicine, acutely sick patients. Subclinical hypothyroidism is where you happen to check the thyroid levels and there's partial problems with the labs, but the patient has no symptoms. So remember we talked about there's that initial phase where people may be going to hypothyroidism, but they're not fully there yet. During this phase, it's not recommended to typically treat the patient because you could hurt them more than help them. So in the asymptomatic patient that has some thyroid function abnormalities, meaning maybe the TSH is a little high, but the T4 is still fine, that's about 8% of the population. Again, elderly and women are more common. Progression to full hypothyroidism only occurs in 3 to 20% of these patients. If people have a positive antibody titer, that may be a higher risk of conversion, or they had prior radioactive therapy. That could also be a risk factor. But again, they have elevated TSH. It's just the T4 and T3 that are normal. Treating these people is very controversial. What we do know is that if the TSH is above 10 and they have any mild symptoms, that's the patient to treat, versus a TSH less than 10 that's asymptomatic. You're not going to benefit that patient. So this is subclinical. It could be the person on trajectory towards full hypothyroidism, but you're going to monitor them more frequently now. If you do choose to treat, we're not going to say, oh, here's 100 micrograms of levothyroxine. That's probably not a good idea. We're going to use low doses. I would start with 25. Give that to them for 6 to 8 weeks and see what happens with the TSH. Does it come back down towards normal? Do the mild symptoms improve a little bit? If they don't, you could dosage increase and then recheck again. You're not going to do aggressive titration in these patients. And the goal is to get the TSH under 3. Okay? The normal range of TSH goes up to 6, so this is getting it more towards the middle of the normal range. Euthyroid 6 syndrome. This is really important in your adult internal medicine hospitalized patient populations. The stress of why people are in the hospital can make their thyroid function abnormal, and they really don't have hypothyroidism. So things that can do this are chronic cardiac patients, infection, pulmonary, renal, oncology disorders, HIV infections. What's typically happening in these patients due to acute stress is they have problems converting T4 to T3. And they may have an elevated TSH, but it's usually under 10. They might have a low T4, slightly low, but when you check free T4, it's still okay. So they have the active component, or the free form is adequate. The T4 might be low, the TSH might be low. They come in with no history of hypothyroidism. They had no symptoms of this prior to admission, but it's related to the acute illness, maybe all the cytokines, all the drugs, cortisol surges, and that sort of thing. So what it's probably due to is binding changes because of, again, all these acute phase reactants. Treatment's not indicated, and typically giving them thyroid hormones will make them worse. So euthyroid 6 syndrome is in the acute medicine setting. There are abnormalities associated with it, but the free T4 is still normal. And that's a big difference compared to hypothyroidism. Free T4 will be low. Okay? So just keep that in mind. Low T4 and a normal free T4 in an acute patient is an indicator they might have euthyroid 6 syndrome. Okay. So I know I've thrown a lot of different things at you, but we're going to go back to the case. The case is a case of hypothyroidism kind of straight out. She has TSH of 11 and free T4 of 3. So for someone, a new diagnosis of hypothyroidism, what kind of options do we have for that patient? Levothyroxine. Okay. Say, just to kind of put this population out there, because I didn't do it before, say she's kind of like an earthy person and she wants something natural that's not synthesized. So she's open to the idea of armor thyroid. Let's just say it. For armor, she's like, I want something more natural. Okay? So you're like, all right, we can do it. What would you look for in the patient that you'd need to tell her from a cultural standpoint that would be reasons not to give armor thyroid, or that she should know before she takes it? What's that? It's an animal product, so what'd you say? If she's vegetarian, is that what you said? No, what were you saying? You're mumbling. I can't hear you. Tell me. It's not kosher, right? Is that what you said? Okay. So if she's Jewish, if she eats kosher, she doesn't want armor thyroid. She just doesn't know it, right? So you have to make sure it's an animal product, but specifically that it's pork. I believe that probably people who eat halal probably don't want pork products either, because there's not like, they're not being blessed, the pigs that get slaughtered, okay? So there are religious and cultural reasons to make sure they know what that is. Vegetarian of different sorts, they probably are going to want to at least make the decision. What else? Any other religious issues that don't like products? Yeah. Vegans, yep. Vegans and vegetarians. Yep. So no substitution would be different than the fact that she's kosher. I would talk to the patient and say, you know, this does come from it's a pork product. So is it something that you do want? We can fill the no substitution and give the Armour Thyroid. So do you know what I mean? It's kind of two separate issues. Because no substitution wouldn't allow us to change it to levothyroxine anyway. We'd have to call the doctor, right, the provider. Does that make sense? Okay. So I just wanted to throw that out there to be sensitive of the cultural issues, but also think of, oh gosh. I'm blanking. Jehovah's Witnesses do not like products from animals either. Okay? So keep that in mind. What dose of levothyroxine would you start with her? Should we say, here's 100 milligrams, or are we going to start more at like 50? What's that? What does she weigh? 170 pounds. 75 mics. So actually all those answers are correct, okay? So one of the things to think about if you do choose to make questions is you have to be smart about the choices you choose, or maybe you do like which of the doses is not appropriate to start, okay? There's not a lot of other questions other than the cultural ones and religious ones we just asked in this person. And again, we had talked about levothyroxine. All right. So I think that's good for today. Thank you guys for paying attention. Thank you for coming to class. And